and from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan and from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Umang Agarwal from Mumbai and Dr. Sameer Parekh from New York, all discussants and participants to this weekend special delight virtual symposium on new kid on the block, newer antimicrobials in the Indian context, and ASCO and IMS updates. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior hematologist and bone marrow transplant physician from Surat in western part of India. I request sir to navigate this program further. Over to you, sir.
Thank you, Mr. Sumit. Well, very good evening to all of you and good morning and good afternoon to all others who are joining from rest part of the world. Today we have got our two guest speakers, Dr. Umang Agarwal from Mumbai and Dr. Sameer Parekh from New York. Our first guest speaker, Dr. Umang Agarwal from Mumbai, is going to lecture us on new kid on the block, newer antimicrobials in the Indian context. And our second guest speaker, Dr. Sameer Parekh from New York, is going to lecture us on ASCO and IMS updates. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Zydus dedicated to life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers for the day, Dr. Umang Agarwal from Mumbai and Dr. Sameer Parekh from New York, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 12th of October 2025 from 11:30 a.m. Indian Standard Time, we have Dr. Riya Balikar from Nagpur speaking to us on transforming treatment paradigm in CLL. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day, all over the country. So these are our discussions for the day. And now it's time to introduce our first guest speaker for the day. We have with us Dr. Umang Agarwal from Mumbai. Let me introduce Dr. Umang Agarwal to all of you. Dr. Umang Agarwal is an infectious disease consultant working at PD Hinduja Hospital and MRC, Mumbai. He is a guideline panel member for the ESCMID, that is European Society of Clinical Microbiology and Infectious Diseases, guidelines on the management of MDR gram-negative infections, and for the ESCMID guidelines on vaccination in solid organ transplant recipients. He was recently conferred the title of Emerging Leader in Infectious Diseases by the Clinical Infectious Diseases Society of India and by the International Society of Infectious Diseases. His research interests include antimicrobial resistance and antimicrobial stewardship and TB diagnostics. Today he is going to lecture us on new kid on the block, newer antimicrobials in the Indian context. Well, I stop over here. Over to you, Dr. Umang Agarwal.
Thank you so much, Dr. Khurana. Just start sharing my slide. Are my slides visible?
Perfect. Full screen mode. Yeah, perfect.
Okay. All right. At the outset, I would like to thank Dr. M.B. Agarwal, sir, and the entire team of MHG for inviting me for this particular talk. And I think this particular topic is of significance and relevance to all our colleagues out here, oncologists as well as hematong, because these drugs are going to come in soon, and they are really going to change the practice of how we practice infectious diseases. So we are going to discuss the following drugs: Aztreonam, which has just gained approval just this week and is expected to at least be available in Hinduja in this particular week. Cefiderocol expected to come soon. Cefepime-Zidabactam sometime in early 2026. Plazomicin, which I'm sure that most of you all might have had some exposure to it. And if I do get some time, we'll talk a bit on cefepime and metazobactam, which also seems to be a very exciting one as well. I'm not going to talk about tebipenem. It's still in phase clinical trials. This is an oral carbapenem option, but still not approved by FDA as yet for clinical use. So I guess all of y'all would agree that the most important bugs, whether it's in an ICU setting or whether it's in the setting of hematong, these are the common bugs that we generally see. And of these are the four major bugs or the four pillars on which the management of MDR gram-negative resistance is really based upon, the most common bugs that we see in our daily practice. Now, whenever we talk about gram-negative organisms, we technically classify them into lactose fermenters and non-lactose fermenters. Well, to a group of all you physicians, it might look a lot like microbiology talks, but this particular microbiological information is really important for our clinical practice and to choose which antibiotic to choose. So E. coli and Klebsiella are enterobacterales, while Pseudos and Acinitos, they are non-lactose fermenters. And I'll tell you the importance of this going forward. So let's start with the question, does the identity of the bug matter? And as a clinician, is it enough to know the phenotypic DST report? All right. Now, suppose that you have an E. coli, which is a carbapenem-resistant E. coli, or you have a carbapenem-resistant Klebsiella, or a carbapenem-resistant Pseudomonas, or a carbapenem-resistant Acinetobacter. Well, you have the entire phenotypic DST report. In spite of that, will it really matter whether it's an E. coli, Klebsiella, Pseudo, or Acinito or not? Well, yes, it would. And I will tell you why. Because the antibiotics that will be used for each of these bugs would be different. So as far as E. coli and Klebsiella are concerned, the carbapenem resistance is mediated by indium and oxa-48, which I'm sure that most of you all would have heard about it. It is an enzyme, basically, which is produced by these particular organisms. On the other hand, when we talk about Pseudomonas, the predominant mechanism of carbapenem resistance is via increased efflux or reduction in porin channels. Rather, NDM is something that we see in an Indian setting, which really complicates matters first or matters more. However, porins and effluxes are more important, which are not carbapenemase enzymes, against which newer drugs such as avibactam, etc., really work. So that is important to know. Whereas whenever we talk about Acinetobacter, the most important mechanism of carbapenem resistant is a non-48 oxa. And the reason for that is that ceftazidime avibactam does not work against these particular enzymes, even though they are oxas. All right. So that's the relevance of it. And I'll go a bit into detail of this. Let's talk about Pseudomonas first. So if you see here, are you able to see my cursor? Is my cursor visible?
Yes, it's visible.
All right. So these are your porin channels. What does the porin really do? It basically helps in transferring the antibiotic from the extracellular to the intracellular compartment. However, if you have a mutation in this porin, then the antibiotic will never really enter into the compartment, into the cell, as a result of which it won't act. So porin channel mutations are important for Pseudomonas. The same way, these are efflux channels, wherein it actively effluxes the antibiotic from the intracellular to the extracellular compartment. Now imagine a situation where instead of one efflux, you have several efflux pump in the cell membrane. Thus, the antibiotic getting out of the intracellular compartment would be higher, as a result of which the efficacy would reduce. And that is the basic mechanism of carbapenem resistance that we see in our Pseudomonas isolates. We have other mechanisms as well, such as AMC beta lactamases, but they are not as important. In an Indian setting, NDM is an important concern, which is not really found in the Western setting. And simultaneously, the guidelines that apply for the West as far as gram-negative organism management is concerned does not apply to an Indian setting. We'll be going a bit more into that in some time. When we talk about Acinetobacter, as I told you, that it is the carbapenemase, it does produce carbapенemases, but these are not the same carbapenemases that are produced by E. coli or Klebsiella, all right? And ceftazidime avibactam won't act against it. Currently, the combination of ceftazidime and ceftazidime avibactam with astrinum for an Acinetobacter is futile. You do not use this combination. It will never work. In this particular bug, the only option that you have would be colistin. Apologies for the spelling mistake. High dose minocycline and high dose sulbactam, at least for now. There are new drugs coming in, such as cefepime, zirabactam, and zolsuparin, which do hold promise, but we'll be talking about them in some time. So let's talk about Astronam avibactam. Okay. Now, the major mechanisms of drug resistance in gram-negative bugs is mediated by enzymes, which are beta-lactamases. So they are basically divided into 4 classes. You don't need to remember the name of all these. The only thing that you need to remember is ceftazidime avibactam is able to inhibit most of the classes except the NDM. All right, NDM impervem, which are the metallo-beta-lactamases. As a result of which, if you have an NDM equal or an NDM Klebsiella, if you use ceftazidime avibactam, it won't work because it is not really hydrolyzing the NDM enzyme. To hydrolyze that enzyme, you really require only astronam. So you can always ask that if astronam is that great, why do we really need ceftazidime avibactam? Well, the problem with astronam is that it gets hydrolyzed by class A, D, and C enzymes. And you really need a drug which can inhibit this enzyme so that you can protect the astronam so that it can act against the NDM E. coli. All right. The NDM enzyme does not act on astronam. I hope that's a bit clear. It might be a bit complex, but this is an important concept that we need to understand. Technically, even for ceftazidime avibactam, the only component that we require is avibactam because that is the beta-lactamase inhibitor. With avibactam, you will inhibit class A, D, and C. You will protect the astronam, and eventually astronam is the drug that is going to go into the cell and produce a cytopathic effect. All right. Now, it's a very complicated diagram. I'll try to make it easy for you. So this is your astronam, which is now going to act on the penicillin binding protein 3. This is the PBP3. All right. And that is how it will cause cell wall, it inhibits the formation of cell walls and eventually cell lysis. Now imagine a situation wherein this particular receptor itself is mutated. In that case, will astronam work? No. Thus, in that case, will astronam or astronam in combination with ceftazidime avibactam work? Not really, because the only role of ceftazidime avibactam or predominantly avibactam is to protect the astronam. All right. So in the setting of a mutated penicillin binding protein 3, astronam will not work. Subsequently, the combination of ceftazidime avibactam and astronam will not work. And this is a problem which is faced only by Indian isolates of E. coli. All right. So that is why whenever you must have heard about something called synergy testing, isn't it? What are we really trying to do in that? So if you see this basically tube, this is the control group. This is the control tube. This tube basically has the E. coli and astronam has been added onto it. But this tube appears murky. That is because the E. coli is growing despite the astronam. Same case goes for ceftazidime avibactam. In the absence of astronam, it becomes murky. However, when you combine astronam and ceftazidime avibactam, the tube becomes light, which basically means a positive synergy testing. All right. So this is something we need to understand that whenever you have an E. coli with carbapenem resistance, specifically NDM E. coli, in those particular cases, you do need to check for synergy testing. And only after that can you use the combination of ceftazidime avibactam and astronam. Otherwise, this particular combination would not work. Now, when you ask us about what is the prevalence of this mutation in our country, well, this is the 2023 data, which shows that the susceptibility of astronam avibactam was 73% for our Indian E. coli isolates. This data comes in from CMC Vellore, who have done a lot of work on this particular phenomena. So in this case, why does it become important for me to know this? That is because I know that 30% of my Indian E. coli are not going to respond to the combination of Cazavi and astronam. So suppose that you are in a situation wherein you are dealing with your patient with E. coli sepsis. The patient is in ICU and the patient is on inotropes. In this particular case, you really don't have enough time to wait for the synergy testing results to come in. And in that case, I would probably directly use a colistin-based regimen or something like that. On the other hand, the same patient, if he is in a setting, in a non-ICU setting, suppose in the ward, and he's suffering from a CR E. coli sepsis, and patient is not looking that unstable, in that case, you can try using ceftazidime avibactam and astronam. and maybe wait for the synergy results to see whether you want to continue or not continue. And the reason for doing that is in general, so whatever data we have comparing polymyxin versus ceftazidime, avibactam, and astronam-based regimen, the clinical outcomes with Casavi and astronam are better for E. coli. But this data comes from the West. For our E. coli isolates, which have around 30% resistance to the combination of ceftazidime, avibactam, and astronam, the same story will not hold true. I hope I'm making sense to you guys. We can discuss that during our discussion thereafter. Now, this was the 23 data. If you look at the present data, this is our data from Hinduja, wherein we have found around the same results as to what Dr. Balaji found, around 63% susceptibility to Astronam avibactam, that is Emblavio. And if you look at the Atlas data from 2023, this is the data from Pfizer. This is across 10 hospitals across India. The Astronam avibactam susceptibility is only 44%. So technically, the new drug that has come in, that is Astronam avibactam or Emblavio, this basically is the drug that has come in replacement of the combination of Casavi and Astronam. All right. So this particular drug for a E. coli isolates would work in around 50 to 60% of those isolates. However, for Klebsiella, it will work 100% of the times. So that is why the identity of the drug matters. So I have a patient in my ICU who has a carbapenem resistant E. coli. I would probably start him on a colistin-based regimen. But if I know that it's a Klebsiella, I would be very happy to start him on ceftazidime, avibactam, and astronam. And that is how the idea of the bug changes our management that way. Now, I'm sorry for this busy slide, just a simple point to make. This combination of ceftazidime, avibactam, and astronam is used by many physicians who have an NDM pseudomonas, all right? But the problem with our pseudomonas isolates, so if you see, these were basically all the isolates of carbapenem-resistant pseudomonas aeruginosa, the one in blue. The one in yellow are the ones who have an NDM pseudomonas, while the one in green who are carbapenem resistant but do not have NDM. Now, if you look at the susceptibility profile here, Astronam avibactam just works in 4% of the isolates. And frankly, when you went in deeper, you actually realized that all these 4 isolates were independently susceptible to Astronam. So there was no real use of Astronam avibactam. Point of query, this particular combination or Emblavio, that is Astronam avibactam, will not work against our NDM pseudomonas. So don't even try using it. Right? Now, what is the difference between the combination that we generally use now and the new drug that is Astronam avibactam that has come in? So now if you see, the concentration of Astronam is 2 grams, while that of ceftazidime avibactam, the avibactam component is 500 milligrams. So the current combination that we are using for Astronam avibactam is actually 4:1. However, what has now happened in the new drug Emblavio, they have increased the dose of avibactam, as a result of which the Astronam avibactam concentration has now become 3:1. And on the basis of that, it is expected to have a higher probability of target attainment. So you expect a better efficacy with Emblavio compared to the traditional ceftazidime, avibactam, and Astronam that you're using. So that's the major difference between the current Astronam, avibactam and the synergy and the combination that we're using earlier. When we talk about its relevance in an Indian setting, for E. coli, I would probably label it as yellow because I'm sure that around 30 to 40% of my isolates are going to be resistant to it. For Klebsiella, I think it will work very well, but it won't work against Pseudomonas or for Acinetobacter. So reserve this drug predominantly for your Klebsiella. You may or may not use it for your E. coli, depending on the clinical situation that you are in. Let's talk about cefiderocol. Many of you all might have heard about it. This is a drug which is manufactured by a Japanese company, Shinoki, and has gained a lot of traction in the West for its unique mechanism of action. So I'm just going to discuss this drug in terms of its mechanism of action, the susceptibility, breakpoints. These might sound very, very complex to you, but I'll try to make it as easy for you as possible. All right. So now how does this particular drug really work? So out here, basically, this is cefiderocol and this is iron. What happens is the cefiderocol has a side chain which mimics iron. All right. So iron is one molecule which is required by a bacterial cell wall to perform its physiological activity. So what does cefiderocol do? Because of the side chain which looks like iron, it competes with the elemental iron which is present in the blood to occupy the receptors and basically gain entry. So that siderophore or the iron which is attached to cefiderocol, that is the one that is actually being recognized by the receptors of the bacterial cell wall. And along with that, the cefiderocol is just coming in. All right. So that is why it's known as a Trojan horse phenomena, which of our Greek mythology. Because the main person that is coming in is the iron. Cefiderocol is just coming as a bystander. All right. Now, what are the unique properties of cefiderocol? Firstly, it passively diffuses through porins like other beta-lactams and active uptake by mimicking natural bacterial siderophores, as I spoke to you about. As a result of which, because the iron concentration intracellularly is high, we do expect the cefiderocol concentration within the intracellular compartment to be high, which is a good thing. And it is relatively resistant to the action of the efflux pumps, thus making it a very nice option in the management of carbapenem-resistant pseudomonas, where efflux is the main problem, which causes carbapenem resistance, at least theoretically. It works against only penicillin binding protein 3. And I'll tell you why the importance of this is. Now, the problem with this particular drug is that it's very difficult to really perform the susceptibility testing for this drug. The discs that are available in India right now, they are not standardized. They are not FDA approved. The discs are not easily available. All right. The CLSI method or the gold standard for performing the susceptibility testing is broth microdilution, which requires an iron deficient media for which you require a particular molecule called Chelex, which is very expensive and not readily available in our laboratories. And the cefiderocol powder itself is not readily available. So even if you have a patient who has carbapenem-resistant Pseudomonas sepsis and you have no other options, if you order cefiderocol, you don't know if you'll be able to do a susceptibility testing. You don't even know that it's going to work. I'll come to the cost part in some time, but that's a major limitation of this drug. All right. These are the FDA approved discs manufacturers and the material required, which is not really available in India. Second is the breakpoint. Now, whenever we talk about the breakpoint, it is basically a MIC value. So if you have a breakpoint of 2 for a particular drug for a particular work, suppose the uh, the Septran MIC is 20 for something like E. coli. So if the MIC of the isolate is maybe around 16, then it is sensitive. However, if the MIC of the isolate is 24, then it becomes resistant. All right. It's basically that particular MIC of that drug against that particular bug, which will make it resistant. Let's put it simply that way. All right. This is again a very complex, very complex table, but I'll tell you, these are the three main societies, the CLSI, UCAS, and FDA, which actually decides on the breakpoints of the drugs. All right. So when we look at Pseudomonas, the CLSI resistance breakpoint is 16. The UCAS breakpoint is 2, while the FDA breakpoint is 4. All right. In this setting, if you have an isolate of Pseudomonas, which has a cefiderocol MIC of 8, for instance, UCAS will say that it's more than 2, so it's resistant. FDA will say that it's more than 4, so it's resistant. However, CLSI will say that it is less than 16, so it's sensitive. So even the major players, the major global players who really decide the breakpoints world over, they do not agree as to what is the ideal breakpoint, and they do not agree what is the ideal susceptibility of this drug. Now, when we go back to our particular study on Pseudomonas that we did, if we look at the breakpoint from CLSI, for Indium Pseudomonas, all right. For Indium Pseudomonas, the susceptibility would have been 71%. However, had I used the UCAS breakpoint, the susceptibility would have been 11%. So when you have, imagine a situation where you are dealing with a complex infection with Pseudomonas or E. coli, and the microbiologists tell you कि cefiderocol जो है, that might work in between 11 to 70% of your isolates. Too big a range and too problematic a thing to really deal with. All right. I'll tell you that in an Indian setting, especially as far as the cost is concerned, it will become all the more relevant to you. When we actually check the activity of these isolates against our Indian isolates of E. coli and Pseudomonas, so if you look at the susceptibility of Pseudomonas, it ranges between 5 to 40%. For Klebsiella, between 60 to 80%. But for Pseudomonas, it's between 26 to 57%. So even then, cefiderocol does not work for our isolates that well. All right. I won't go into the PK/PD concerns. It would be this thing. However, we need to understand that two large trials have been done for the assess the efficacy of cefiderocol against the standard of care for the management of bloodstream infections and HAP caused by carbapenem-resistant organisms. And they have found cefiderocol to be non-inferior, not even superior. All right. Each dose of cefiderocol is for $5,000. Now I'll come to the costing. Let's talk about this. So let's start the cost. And now I'll be talking about the cost that an Indian buyer would pay for this drug because it's not available. It needs to be imported. One pack of cefiderocol, that is around 10 vials of 1 gram each, is for 4 lakhs. All right. The traditional dosing is 6 grams per day. All right. So if you're using it to treat an LRTI, the cost of the therapy would go up to 24 lakhs. For a pyelonephritis, a 2-week therapy will cost 36 lakhs. However, if it's an osteomyelitis which requires 6 weeks, the cost of therapy would be 1 crore. How can you ask your patient to pay such a huge amount for a drug which you don't really think is good? You don't really know whether it's going to work or not. Yeah. So that is one concern about this drug. Of course, the other drugs is because you're importing it from private vendors, we are not very sure about the quality of the drug. There have been reported side effects of bradycardia and cardiac arrests with this drug, and we are not very sure whether it works that well in the extrarenal sites. For pyelonephritis, there is some data to work, but for lung, blood, not much data. All right. So there's a lot of problem with this particular drug. And if we talk about only the susceptibility pattern, it works well for Klebsiella, but well, we have other options available as well. It does not work for Acinetobacter, and for Pseudo and E. coli, questionable use. All right. So that's the take on cefiderocol. So this is one drug that all of us are really looking forward to, cefepime-zidibactam. And this is a drug by our Indian company, Wockhardt. And I'm sure that all of you all who follow Indian markets, the Wockhardt stock has got crazy because of this drug, Saneage. It's expected to be the next game changer in the field of antimicrobial resistance. It has a very different mechanism of action. So I told you about penicillin binding proteins, isn't it? So what do these proteins really do? They are basically enzymes which are responsible for cell wall production. So if you are able to inhibit the activity of these proteins, the cell wall will not form, as a result of which the bacterial cell will die. It's as simple as that. Now, how this drug works is zidibactam itself acts against penicillin binding protein 2, which is a very, very novel mechanism. That was not the mechanism of any other drug till date. All right. In addition to that, it enhances the activity of cefepime against PVP1 and PVP3. All right. So it makes cefepime much more potent. So zidibactam itself is an intrinsic activator of the drug. It's a PVP. It is an intrinsic inhibitor of PVP2, while it also enhances the activity of cefepime against the other PVPs. All right. So zidibactam is not a beta lactamase inhibitor. It does not destroy enzymes. All it does is increases the affinity of cefepime to work against that particular bacteria. The basic theory behind this is that if you're able to achieve this, presence of any enzyme within that organism will not matter. This drug is expected to work equally well because the enzymes really won't matter in extracellular environment. All right. I'm not going to go through this. This is too technical. I'll go through this. So this is the activity of cefepime-zidibactam against our isolates of E. coli, Pseudo, and Klebsiella. For Indium E. coli, 100%. For Klebsiella, 75 to 100%. While for Pseudomonas, 90 to 100%. So this drug does seem to be promising that way. And if we look at our own data, so this is our data which we had done at Hinduja. Using this drug, we found 100% susceptibility against any carbapenem-resistant Pseudomonas. It did not matter whether that particular bug had NDM or not. All right. So this particular drug is expected to work. When we talk about clinical data, there's a recent global phase 3 trial on complicated UTI, which was released where it was expected to have a 90% efficacy compared to meropenem. A phase 2 Indian study has been done. The results are awaited, but we are hearing it from the company that the results are expected to be good. The compassionate use program again is yet to be published. I myself have used this drug in around 3 patients, and they have done exceedingly well. And these were difficult to treat cases. One of them was actually a patient who had a lung abscess with carbapenem resistant Pseudomonas carbapenem resistant Acinetobacter, along with Klebsiella, carbapenem resistant Klebsiella. I'd only used the combination of Cefepime, Zidobactam, and Sulbactam. It had done quite well. Overall, what I hear from my other colleagues across India, it seems to be working well for them as well. And sepsis trial is going to be the game changer in the management of carbapenem-resistant infections. It is basically going to compare ceftazidime zidobactam against the presently available treatment for carbapenem-resistant bugs. So it's going to be against Astronam avibactam, Cazavi plus Astronam, etc., polymyxins. And we wanted to understand what the efficacy of this drug is going to be in terms of mortality. So we are expected to launch this trial soon in early 2026. It is being headed by CMC Vellore. When we talk about our own Indian experience, published experience, let's talk about that. There have been several centers across India. So this study is from Hyderabad. One of these studies is from this is from CMC Vellore. This study again is from Hyderabad, some other hospital, and this is our study from Hinduja, wherein the efficacy of this drug was found to be great. All right. So this seems to be a good drug to use in future, and probably the most promising of them all, at least for the time being. If we talk about relevance in an Indian setting, I have been a bit harsh about this drug as far as acinetobactam is concerned. That is because we don't really have enough data on acinetobactam, and you really need to combine this drug with sulbactam to have good efficacy against acinetobactam. Once this drug comes into clinical use, we will know more. I have some time, or
Yes, you have. Because our next lecture is at 8 o'clock. That's why. Yeah.
okay. So the next one is plasmomycin. And basically, plasmomycin is something you guys might be using. The major advantage of this drug is that it has 2 separate side chains compared to the original molecule of cesomycin, as a result of which it is expected to be active against the presence of aminoglycoside modifying enzyme. So it is expected to be more robust against the activity of aminoglycoside degrading enzymes. However, we need to understand that it will still be susceptible to the activity of 16S RMT. It's a very fancy word, just don't think about it so much. Only thing you need to know, the major problem that we have in India is 16S RMT. So technically, for an Indian setting, probably these addition of side chains do not really make much sense for us. Now, when we look at the data, as far as carbapenem resistant E. coli is concerned, the susceptibility is expected to be around 50%, while for Klebsiella, it doesn't work that well. So this drug is presently only being used for the management of carbapenem resistant E. coli. They are trying to, we don't know the activity of this drug against Indian E. coli, which is the major issue. However, we need to understand that whenever you have an NDM in E. coli, it generally has a linked mutation to the 16S RMT, the enzyme that deactivates plasmomycin. So in all likelihood, if it's an Indian E. coli, it will come in with that enzyme of 16S RMT and probably won't work, but we still need some data pertaining to that. It is a very costly drug. Very costly drug compared to amikacin, and the toxicity profile, there is no benefit of toxicity profile compared to amikacin or gentamicin. If I have to put it in an Indian setting, may or may not work for our carbapenem resistant E. coli. Definitely not. It's not going to work for the other 3 as well. Okay. So I think I'll stop there. Cefepime and metazobactam we can discuss later, but if there are any questions, I'll be happy to take them up.
Thank you, Dr. Umang. Wonderful lecture. It was nice and it was a fantastic lecture because we
Thank
don't
you.
know so much of microbiology part of it. Which drug to give in which setting is important actually. Fantastic. Lovely. Thank you so much. And I now request all our discussants to please put the hand raise sign so that we can start our question session with Dr. Umang. Regarding this ceftriaxone, Dr. Gopinathan, yes. Please go
Yeah.
ahead, Dr. Gopinathan.
Good evening, sir. I think you updated us about all the new molecules. I just want to know, understand, where do we find the role of plasmamycin, the current data?
So as I told you that it is currently being marketed just for E. coli, and the data for E. coli is also not that promising. You have other good drugs for it. You can use fosfomycin, you can use TG-cycline. Uh, Against NDM E. coli, at least I don't expect it to work much. They still don't have enough data about that, especially in our particular isolates. So, and it's a very, very expensive drug. So my use of this drug is going to be very limited. I have not used it in any of my patients as yet.
Okay. Okay. Fine.
Yeah.
Thank you, Dr. Gopinathan. My request to Dr. Umang, can you please give a flow chart and to for us to easy way to understand which drug to use when? Verbally also, if you
Okay.
can just tell us if
Sure.
this is there, this is
So
how.
technically, if it's an E. coli, I would I'll talk only about the ICU setting. Let's put it that way. So that would give you the most this thing. In an ICU setting for an E. coli, I would probably go in for a fosfomycin based regimen. The fosfomycin MICs are quite good. TG-cycline also works quite well. Combination of ceftazidime, avibactam, and astronam is something that I can try only after the synergy is proven. Until that time, I would probably use a polymyxin based regimen. All right. If it's a Klebsiella, I would use the combination of Casavi and astronam. If it's a Pseudomonas and Acinetobacter, the present options are only polymyxin-based regimen. For Acinetobacter, maybe use polymyxin with high-dose minocycline or high-dose Selbacter. And this is a very general rule. It really depends from patient to patient. What kind of infection has he come in with? What is the site of the infection? What are the comorbidities? So lots of things have to be looked into. But this is on a very, very general overview that I'm talking about.
Perfect. Thank you so much. Anybody has any other question? Yes, Dr. Thanda.
Yes, thank you for your talk, sir. In our setting, CRA, government-resistant E. coli are very headache organism. So, what about the TG-cycline is sensitive in most of our cases. So I'd like to know your opinion. When patients develop CRE and we give sensitive drugs, and it's still present in Ricatra specimen. So should we treat again if when the patient is stable, when the patient is improving?
Okay. So see, these susceptibilities, what I've spoken about, are more relevant in an Indian setting. I don't know how it works in my. I assume that you're from Myanmar, right, madam? Yeah.
Yeah.
So I'm not sure how the susceptibility is there in your part of the world, but by and large, TG-cycline, it really depends on which indication you're using TG for. So if it's an intra-abdominal sepsis, TG will work very well because it has a very good intra-abdominal penetration. It works very well for skin and soft tissue infections as well. However, if you're treating a pyelonephritis or if you are treating a patient with a bloodstream infection, for pyelonephritis, none of the tetracyclines really go into the urine. So
Oh, I see.
whatever you
Yeah.
do, so TG is never going to work against them until unless it's a renal parenchymal disease. And for a bloodstream infection, because this particular drug has such a large volume of distribution, the plasma concentration of this drug is not that great. So you cannot, so you won't achieve decent amount of levels of TG-cycline within the blood. So I would probably not use it alone in a patient with sepsis. I would combine it with either polymyxin or colistin then.
Yeah, we usually combine it. And I'd like to know about this stenotrophomonas infection. So,
So for
yeah,
so as we all
it's
know,
not, most of the drugs are not sensitive.
Yeah.
Most of the drugs are not sensitive to this organism.
Yeah. So
So what should I do?
Stenotrophomonas is intrinsically resistant to meropenem. The treatment for choice for stenotrophomonas is either going to be cotrimoxazole or high-dose minocycline or a quinolone. So these are the three ones. However, if you actually have these to be resistant as well, then the combination of ceftazidime, avibactam, and astronam works quite well. And now you can technically use astronam avibactam as well. So this particular bug actually has an intrinsic metallo-beta-lactamase, that is an endium-like molecule. All right. Some
Yeah.
of the labs report it to be sensitive to ceftazidime, avibactam and all, but please don't go by that. It will never work alone. You always have to combine it with astronam for it to work. But the first line would be cotrimoxazole, high-dose minocycline, and quinolones.
Thank you, sir.
Many of our wards are susceptible to this. It's like endemic for this bug actually. So
Yeah.
what is the mechanism why there is a endemicity in some of the wards only? Many centers they don't have, but some of the centers only does have such things.
See,
So
by
what?
and large, it is a bug that is usually selected out. Most of your patients would be on meropenem, and especially this bug usually comes in from the lung.
Okay.
So उसमें ऐसा होता है that you have by and large with meropenem, all the other bugs die, but Cynotrophomonas is left behind because it's resistant. मतलब it's intrinsically resistant. The second problem with steno is it's also a nosocomial infection. So if you're getting a lot of stenos, then you need to do something about your infection control practices, all your bundles and everything that needs to be sorted out again once more.
Thank you. There is one question which has come. Oh, that's all. Well, anybody has any other question? Dr. Gopinathan, you have a question? Well, so in that case, thank you, Dr. Umang. Wonderful lecture. Here, one question has come from Dr. Sailesh. Post-transplant, day +7, blood culture showed Klebsiella carbapenem resistant, but sensitive to meropenem plus EDTA, poly B, colistin, and TG. And carba are showing OXA 48 NDM. So in this scenario, will you change to ceftazidime, avibactam, and aztreonam, or meropenem plus EDTA plus colistin?
See, the problem with that meropenem plus EDTA formulation is, firstly, it's not FDA approved, and it's probably got approval from the state level DCGI, not from the central DCGI. The amounts of EDTA, the basic mechanism, the same goes through for ceftriaxone sulbactam EDTA. That's a very common drug in clinical use right now. The theory behind EDTA use is that EDTA is a iron chelator. It's basically a metal ion chelator. And the metallo-beta lactamase, when we talk about it, it has a zinc ion in between. So the theory is that if you use EDTA, it will destabilize the zinc and eventually it will cause destabilization of the NDM as well. All right. The problem is that the amount of EDTA that you require for it to actually be effective is to the extent of 9 grams per day. That is the amount that you require. A meropenem EDTA, whenever you're using, the amount of EDTA is too low in that. And however, you do get susceptibility on the disc. That is because these guys have put in a lot of EDT in that disc. So that is how the clinicians get confused. All right. So even though in vitro it shows susceptible, when you use it in vivo, it's never going to work. Second point about TG-cycline. TG-cycline, as far as Klebsiella is concerned, is not a very great drug. At least in our data. I don't know how your data looks like. And whenever you're talking about susceptibility, you need to be very careful about what susceptibility really means. The FDA says that if your sensitivity is less than 2, then it's susceptible. But we have enough data to show that if your MIC of that particular TG cyclin is beyond 1, it's not going to work. So even if it's 1 or 2 and it shows sensitive, I'm never going to use TG cyclin. As far as colistin is concerned and Klebsiella is concerned, well, I would still prefer a combination of ceftazidime, avibactam, and astronam compared to colistin because there is enough clinical data to show that it works very well compared to colistin.
Great. Fantastic. Fine. So I think there are no more questions. Anybody else? Fine. So thank you, Dr. Umang. Wonderful,
Thank you so much.
wonderful discussion. Thank you for updating us with these new molecules. Thanks a lot. Thank you so much. And now we have a second guest speaker. That will be the next speaker will come out at 8:15 p.m. So we'll take a break for half an hour. Morning,
Hi,
Dr.
hi,
Amit.
Amit.
How are you,
Can you
Dr.
hear me and see me okay?
Yes, fine. Absolutely fine.
Great, great, fantastic.
So I will introduce you because we just finished our first lecture.
Just want to make sure all the slides and all were
Yeah, you can check your
also.
slides once.
Are you able to see the slides?
Yeah, perfect. Yes.
Is it in full screen or in presenter view?
Full screen.
Full screen.
So if you can just unshare your screen once, I will. So, Mr. Nikhil, can we start?
Yes, sir.
So welcome back after the break. And now we move forward for our second guest speaker. We have with us Dr. Samir Parekh from New York, and he's going to lecture us today on ESMO updates. And let me introduce Dr. Samir Parekh to all of you. Dr. Samir Parekh completed his clinical training in hematology and oncology, followed by postdoctoral training in Dr. Ari Melnick's lab at Albert Einstein College of Medicine. He currently serves as a director of the Multiple Myeloma Center of Excellence at Mount Sinai and is a professor of hematology, oncology, and oncological sciences at the Ikahan School of Medicine at Mount Sinai. His research focuses on the pathogenesis of hematological malignancies and the development of individualized precision medicine therapies for these diseases. His lab uses an integrated systems biology approach to study genome-wide methylation, gene expression, and DNA sequence variation to understand pathogenesis, develop biomarkers, and guide personalized therapy in B cell malignancies, particularly multiple myeloma and non Hodgkin lymphomas. Today, he's going to present us the ASCO and IMS updates. And well, thank you so much. Over to you, Dr. Samir Parekh.
Well, thank you, Amit and Nikhil and Dr. Agarwal for inviting me again to your prestigious seminar series. We had a really nice discussion last time, and I'm looking forward to continuing that with this update. I'm actually going to uh, talk about news from two conferences, ASCO and more recently the International Myeloma Society meeting uh, that was held in Toronto. And I hope that these updates are useful to you. They will both give a view back in trials that started many years ago and a view forward in trials that are ongoing and starting to show promising results. So I hope it will give you a lay of the land and idea of where myeloma is going, and we will have an opportunity for Q&A, and I would really encourage all of you all to participate, ask questions as you think of patients and situations that you all see, because I think these are all going to ultimately translate to your clinical practice. So with that, I'll get started with the ASCO updates. These are my disclosures. And then the first abstract or talk that I'm going to discuss are the long-term results, that is over 5 years with cilta-cel. This was from the trial Cartitude-1 that was done in a multi-center fashion, enrolling almost 100 patients about 7 or 8 years ago. And what we saw in our center uh, earlier this year was that two-thirds of the patients at our center that had received just this CAR T and nothing else after that still remained alive, and majority were in remission. And this was astonishing because these were patients that would have otherwise gone to hospice. Most of them had gotten 7, 8 lines of treatment. They were all triple exposed, refractory, post-transplant. And really, it is remarkable how good the quality of life is for some of these individuals. They are living in other states, traveling back and forth to our center to check in once a year. And we do an annual PET and CT. So this talk was given by Peter Voorhus at the ASCO meeting, and the key takeaways from the talk was that a third of patients, when we went to Janssen and they looked overall in their entire cohort, had actually remained progression-free for 5 years. So what we saw in our center was then recapitulated in the overall product, and these patients, although some centers did not have serial MRD assessments, our center did it with PET-CT and showed that they were all MRD negative by next generation sequencing and PET-CT negative as well. We have earlier in the year published a paper, Chen et al. Is the reference in Blood Advances, where we show that 5 years consecutive MRD and PET negativity is associated with long-term overall survival, even if we take the patients off treatment, off maintenance. And this suggests cure, which is the definition in most hematological or solid tumors. If you go out 5 years, you're off all treatment and you have no evidence of disease continuing, that is cure. And this was really, really exciting because it was the first evidence that CAR T could have curative potential in relapsed and refractory myeloma. The background to the study before CAR T is shown in this figure, where previous therapies did not expect to even reach 1 year. In fact, the median time of progression prior to this was about 4 months and expected to be maybe a year or so. But when Cartitude results came out and they showed median PFS was nearly 3 years, that really was astounding. So this 5-year update essentially follows the patients that are still being followed on the CARTINU study. So after the clinical trial, the FDA had mandated that patients be followed for 15 years to carefully monitor for side effects and events. And in the CARTINU study, we found this finding that 1/3 of the overall cohort were still alive in long-term follow-up. And this was their curve. And you can see we are now seeing a plateau, which is really, really exciting. As I mentioned before, all 12 patients that were and were also PET negative. And there were no new additional concerns in terms of secondary effects. For example, there were no new cases of Parkinsonism or other motor neuron disease. Uh, there were a couple of solid tumors, but both sort of unrelated to this. And some infectious diseases were also deemed unrelated. And overall, patients were having good quality of life even after 5 years. Some translational studies done in the context of the apheresis product showed that neutrophils in the apheresis product were not good. So if you had more neutrophils or the T cell to neutrophil ratio was bad, then the outcome for these patients was poorer. If you had more T cells, patients were more likely to live for 5 years progression free. Intuitively, the greater the amount of CAR Ts and particularly the naive CAR Ts in the infusion product were also associated with better outcomes. And in fact, this is reflected even after the CAR Ts are infused and they start expanding. At the time of peak expansion, greater amount of CAR Ts. And in fact, CD4 CAR Ts, which we have now seen to be more effective than CD8 CAR Ts, was associated with 5-year PFS. We have just had a manuscript accepted to Blood Advances that also describes the microenvironment characteristics of patients with long PFS, and that should come out in the next month or so. I will also be talking about Cartitude 4 at ASH, and perhaps if invited next year, I'll give an update about the earlier lines of treatment and what is associated with long-term remission in that setting. So summary from this abstract was, for the first time, long-term follow-up from Cartitude-1 shows that 1/3 of the patients remain treatment-free and progression-free for at least 5 years, showing the curative potential of cilta-cel in relapsed refractory myeloma. What was notable was that patients with high-risk cytogenetics and those with extramedullary plasmacytomas were equally likely to be progression-free. So cilta-cel was able to overcome these adverse cytogenetics and characteristics associated with poor prognosis that are seen in newly diagnosed patients. And correlative studies showed that immune fitness was important in the drug products, and CAR T expansion, if it was better, then of course we had higher effector to target ratio, so more CAR Ts could kill the myeloma more effectively. This ASCO presentation was accompanied with a JCO article, which was led by Dr. Sundar Jagannath from my institution, and you all are welcome to look at that for further details. I'm going to move on to the next talk, which I thought was very interesting. These were early results from a tri-specific antibody, which is proving to be very exciting for relapsed myeloma. And in sharp contrast to Cartitude-1 long-term follow-up, we are now looking into the future. This tri-specific is actually at the moment just having a number, GNJ532, but it combines both targeting of GPRC and BCMA. And you can see in this cartoon how both of these antigens are attacked by this molecule, and then it recruits T cells, which then do their job of secreting granzyme and perforin and causing myeloma cell kill. What Janssen did with this molecule is that they also re-engineered the binding domains so that there's less antigen escape, and the safety profile that was seen with their prior GPRC5D bispecific talquetamab has potentially improved with this study, as I'll show you. Also, the CRS profile has been modified by modifying the FC domain, and you will see the results soon. So what did they find? This was a phase 1 study, so there were dose escalations performed and ultimately led to the identification of a safe and effective recommended phase 2 dose of 5 milligrams sub-Q followed by 100 milligrams just given once a month sub-Q. So this makes this very important for community practitioners that can just get the patient in once a month, and that's all that's needed to control their disease. The patient characteristics in this case were important because there were even a subset of patients that were exposed to prior BCMA and prior GPRC5D therapy. As you can see here, 100% of the patients were refractory to IMiDs and anti-CD38, and about half were triple refractory, and 95% were refractory to the last line of treatment. In terms of toxicity, I'd mentioned there was some modification in the molecule and compared to talquetamab. So while the expected hematological toxicities were still seen, taste-related and nail-related toxicities were seen but were not high grade. They were all mostly low grade. And at our institution, we now have a very common set of recommendations that we give patients to manage both the dysgeusia as well as nail and skin peeling that can occur with these drugs. And with supportive care, vitamin E and other things, they are able to actually tolerate it quite well. In fact, the reduction in the frequency of the dosing with this tri-specific antibody is actually remarkable because it makes the product less toxic and actually even potentially more effective. So here, in terms of CRS, which is the dreaded complication with both CAR-T and bispecifics, you can see here majority of the patients had grade 1 CRS, about 53%. A few had grade 2, but nobody had grade 3 CRS. And CRS was also mostly seen within the first cycle. After that second cycle onwards, there was absolutely nothing. Prophylactic tocilizumab for those giving bispecifics is now approved by the NCCN guidelines for all the bispecifics. So we are giving it upfront to our patients after the first step-up dose, and they do extremely well. Very, very few patients really get sick. This actually has allowed us to transition our patients to an outpatient setting much faster than we did earlier, where patients used to stay in the hospital for a full week. In terms of infectious toxicities, we still see infection signal. Again, mostly grade 1, 2, with respiratory tract infections being the most common one. Now we have standard recommendations for giving all our bispecific patients IVIG, and there were 2 patients that died in the setting of hypogammaglobulinemia. So this is extremely important with monthly IVIG maintenance to keep the level more than 400 milligram per deciliter. If you look at the weight loss, which is a very good indicator overall if the patient's dysgeusia is really affecting them long term, you can see in these curves that both patients at the phase 2 dose as well as all doses ultimately over time recover their weight. So this is very actually reassuring to me because we see the same thing in clinical practice. The initial weight loss that patients have can actually be maintained with monitoring, supplements, and such, where they can actually regain weight back to baseline and above in vast majority of the patients. So now coming to the efficacy results, the outstanding results were that there was a 100% response rate in the BCMA or GPRC naive patients. And although response rate dropped in the exposed patients, there were still patients that went into VGPR or better. So this is extremely important. The efficacy in naive patients was phenomenal, approaching that of CAR-T. And if we see these swimmers plots of patients, you can see many of them have these green arrows, which suggest that they were still responding and on treatment at this data cut. So we are seeing ongoing responses in the vast majority of patients in this cohort. And you can see in the red are the patients that are actually in complete remission or stringent complete remission, vast majority being at the RP2D dose. If we just look at those patients quickly, the RP2D dose PFS curve looks amazing at 95%, even though this is a short follow-up of 12 months. Comparatively, the median PFS with the single antibodies was actually around 50%. So this has remarkably improved the efficacy of bispecifics by going into the trispecifics. I'm going to pause here just to make sure we are able to apply this data in case settings. And I had actually conducted this poll. We don't have that mechanism with you all, but I will ask the same question I asked the audience at the ASCO update, that if we have now a young patient, 50-year-old female, who has relapsed IgG kappa myeloma after daratumumab, Velcade, Revlimid, and Dex, she went to get autologous transplant after her induction and received Len maintenance. As first progression or first salvage, patient received DARA plus KPD. So she has now got 2 lines of treatment, has an M spike of 0.5 grams per deciliter. This is usually the cutoff which we use to screen patients for clinical trials. Has no extramedullary disease or favorable cytogenetics. There are now several options for treatment. We can give her CAR T. We can give her either teclistamab or talquetamab as single agents, or we can do a clinical trial with the tri-specific antibody. So not surprisingly, vast majority of the recipients answered cilta-cel correctly. The reason for not using teclistamab upfront is that we are finding more and more with correlative studies that patients given the bispecific upfront can develop mutations and loss of the target antigen. So if there's an intent for giving curative therapy with CAR T, it is better to do the CAR T upfront and then use bispecifics for salvage. Another talk that I wanted to focus on now, this is from the IMS meeting. I'm showing the cut from EHA, is about a third bispecific, which is targeting a completely different antigen called cevostamab. And cevostamab is on its way to get approval in the US. We were part of the early clinical studies, and this is updated data from them. So let me tell you a little bit about the molecule. The molecule is a bispecific that targets an antigen called FcRH5. The gene encoding this is FcRL5, but this is uniformly expressed in myeloma cells and actually is expressed even after patients go through talquetamab or teclistamab. The dual binding was tested in a large clinical trial that Genentech did. The important variation in this trial design was that they had fixed duration of treatment built into their phase 1, phase 2 studies. And they allowed patients that had seen prior BCMA treatment into the study. So we could actually even tell whether this maintained efficacy in patients relapsing from prior BCMA bispecific, or in some cases, patient had received belantamab, which is a BCMA antibody drug conjugate. So this was the study design. They allowed prior BCMA, ADC, CAR T. They allowed good performance status patients, and there was a dose escalation. Ultimately, they did reach the RP2D dose, and the characteristics between the prior ADC, prior CAR T were very, very comparable, with about a third of the patients or more having extramedullary disease as well. In terms of the adverse events, um, most adverse events were comparable again in both cohorts and were fairly typical of any bispecific. Infectious complications and cytopenias were the big um, complications. Most of the CRS events were grade 1 and 2, and we have not seen any safety signal that's concerning. Here, this is the CRS events in the different cohorts, prior ADC, prior CAR T, and all patients. So CRS predominantly was grade 1, as you can see, and treated with standard therapies like tocilizumab and steroids. Coming to the efficacy data, the overall response rate was comparable to teclistamab or talquetamab at 73%. And you can see here the VGPR rate was extremely high in all the patients, even that had got prior CAR T. Similarly, prior ADC patients had a fairly comparable response rate to the overall cohort. And this suggested that this drug may be a good options for patients that have already gotten prior anti-BCMA therapeutics. And this gives us hope because, patients go through CAR-T expecting they will be cured, but if they are not, there are still options emerging that we can salvage that are quite effective, as shown over here. And in the swimmers plot, you can see that there are patients having ongoing responses both in the prior ADC and prior CAR-T group over here that are going beyond a year and more. So this is something really hopeful for us. Not unsurprisingly, the expression of FCRH5 on the tumor cells was pretty high and did not differ between the patients that got prior BCMA and prior CAR-T. So this is very important. The interleukin 6 levels, which are a surrogate of T cell activation, is shown here. And you can see here, again, there's good T cell activation with prior ADC, slightly less with prior CAR-T, but really no significant difference. Similarly, granzyme secretion by the CD8 CAR-Ts is another surrogate measure of response. And you can see remarkably here on the right side, there is greater T cell activation in the responders as compared to non-responders. We are actually diving deep into this correlative data and trying to figure out how to improve the responses even in the patients that are getting suboptimal responses to cevostamab. So in conclusion, cevostamab is a highly active agent in relapsed myeloma who are triple class refractory and received prior BCMA ADC or CAR-T with response rates comparable to just monotherapy. These antigens are abundantly expressed and remain expressed after patients go through these prior therapies, which suggests that there is a potential future role for cevostamab in the management of patients progressing on BCMA, ADCs, or CAR-Ts. One important point I wanted to touch on that was discussed at the International Myeloma Society meeting was that there is an update to the response criteria that is underway, and you will soon see this being published. It is not finalized, but I wanted to convey the sense of where response criteria are going, and I think this is a very sensible change. The MRD assessment, whether it is being done by flow or next generation sequencing, is now becoming central to response assessment. And because of the differences in different techniques, negativity is being defined at 1 into 10 to the 5, whereas more advanced testing like NGS can detect it to 1 into 10 to the 6. So to simplify the criteria, two categories, MR and stringent CR, are going to be taken away. And this is good because we largely use PR or better, VGPR or better, or CR in our response criteria. And if a patient has progressive disease or so, we have very clear evidence that treatment needs to be changed. The other big change is that prior suggestions for using CT-based lesion measurements are now being replaced with functional imaging. So either using serial PET CT scans or, where available, diffusion-weighted MRI are being recommended. And I think these are all sensible changes to the response criteria, which will come about soon. One other very good and welcome change by the patients is that the 24-hour urine is going to be probably removed. This was a cumbersome test for both patients as well as the labs, and I'm happy to see that because it led to a lot of deviations and ultimately just did not contribute that much to response assessment. So with that, I'll stop and open it up for questions. I hope the updates from ASCO IMS were useful, and I would love to hear how you think this will impact your care as bispecifics and CAR-Ts are rolling out in India, and I'm open to questions from the audience.
Thank you so much, Dr. Samir Parekh. Wonderful talk, and it was a great update from you. Thank you. Thanks a lot. I request if any discussions are there to ask any question to Dr. Samir Parekh. So with this update on myeloma for triple class refractory, what would be your flow chart now?
Yeah, that's a good question. So I think the flow chart depends on certain patient factors and disease factors. As always, you have to weigh the risks and benefits and to personalize care for each patient. Um, if we have young patients that are triple refractory, we are tending to offer them CAR T more and more. And we are actually having patients come to us asking us for CAR T more and more. So this group is sort of self-declaring. How to do this safely is becoming the question. And at our institution, we are assessing for antigen expression by immunohistochemistry. So just like you do CD138 staining for plasma cells, we now do co-staining for these different antigens, BCMA, GPRC5D. So it gives us an idea that they have enough antigen expression, and then we can guide them to the right CAR T, because now there are GPRC CAR Ts also available. Soluble BCMA is another important and easy test that is being used in our clinic. We generally find patients fall into two groups. Either they have very low BCMA or very high BCMA. If they have very low soluble BCMA, either because their BCMA locus is lost or they have low disease burden, that makes them less amenable to going for CAR T or some such. If patients have more advanced age, and here I'm talking of patients in their 80s and 90s, we are then thinking more about bispecific antibodies for them. These are actually very well tolerated even in the elderly. What we do is we give upfront tocilizumab and space out the bispecific quite quickly in elderly patients, so they get less infectious complications, less toxicities, but maintain very good quality of life and disease control. And this is really well tolerated. I have a 97-year-old patient who is on teclistamab. In fact, she is doing so well. She went to Jamaica over the summer and just came back, and she will get her next dose next week. So you can do this quite safely in elderly patients. Is there still a role for the conventional cytotoxics? Yes. There are two important points here that I would like to make. So patients that go into CAR T or bispecific with kinetic disease or a high disease burden generally tend to have more CRS, ICANS, and other toxicities. We follow this with ferritin, for example, as a cheap biomarker. They will have high ferritin at baseline, and they generally don't do very well. So it is important to control their disease before you get them into the CAR T. And you can do this with conventional cytotoxics like DCEP is a four-drug cocktail that's everybody's wheelhouse. Um, if patients have not seen prior second, third generation drugs, of course, you can give DARA, KPD, and the like. There is a large movement in the US to give talquetamab as a salvage or as bridging therapy prior to CAR T. I think jury is still out on that. We have been using it, but I'm worried, as I mentioned earlier, that giving this even for a brief interval will ultimately cause antigen loss, and later on, when the patient needs talquetamab, it will be less effective, and the PFS at that point may be compromised by using it up for bridging. However, it is very effective. So even 1 or 2 cycles really debulks the patients to get them into CAR T. So these are some considerations. I hope that answers our question.
So CAR T always first for the young people, and then followed by the bispecifics. In that sequence, we must go. And that
Yeah,
also bispecific Talcet or teclistamab, and then you got the newer one which is coming up, that is civostamab.
yeah, that's right.
That would be the way out.
Yeah, the trispecifics are looking exciting because they are going even into first line therapy, and there are now clinical trials using bispecifics along with first line to see if patients can just go into complete remission without ever needing the CAR T in the first place. So that we'll have to see as long-term data comes out. I was curious to ask you, you may have heard of the Aquila trial, which described the use of daratumumab in smoldering myeloma high-risk patients.
Yeah, we had
And it has
MSG meeting only. We had a wonderful talk on that. Yeah.
good. So has that actually changed practice in India? Are people
Not
starting to
yet.
use?
Not yet.
Okay,
Think this
good.
will
Yeah, even we are not convinced by the trial, and in fact we have a large multi-institution effort at trying to tease out which smoldering patients really can benefit from treatment, because the trial, although led to drug approval, we still find many smoldering patients that have high risk disease that continue to smolder along for years without transforming to active myeloma. So I find that preemptively treating them with daratumumab is more treating our anxiety than the patients. And in fact, what it does to subsequent therapy, in a couple of years, the treatment landscape for newly diagnosed might completely change. So why compromise that for the patient? So we are also not changing our practice pattern just yet. I'm reassured to know y'all are not doing that too. So that's great.
I have a question. How do you catch hold of high-risk smoldering myeloma patients? How these patients come to you? Because in India, it's
Most of the
difficult.
time,
Because in India, it's
yeah,
difficult. Unless patient is symptomatic and they come to the OPD, the selection of the patients with this high-risk smoldering multiple myeloma, that is little bit a big task in India, because the
I'll,
patient
I'll tell you. So
is
this is good because actually I'll tell you the vast majority of even active myeloma patients in US are referred because they go for their annual physical checkup. Everybody goes to their primary care doctor for an annual physical. And at that checkup, the physicians order CBC chemistry, and the lab sees an elevated total protein, and they reflexly do SPEP and IFE. And if a paraprotein is picked up, then the primary care says, oh, okay, paraprotein equals go to hematologist. Now you have to figure out whether you have MGUS or smoldering or um, newly diagnosed. And that's how most patients are referred to our clinic. They are absolutely healthy, just going for their usual checkup, or they may be going to their cardiologist or nephrologist for something else, and a lab test is done, and that's how they get picked up. Then we do the marrows and all that and try to place them whether they are MGUS, smoldering, low risk, high risk, and that's how the story starts. And you may have heard there is a research ongoing from Irene Gobriel from Dana-Farber, where because now mass spec is available, they are detecting MGIP, which is a monoclonal protein preceding MGUS in most individuals that have MGUS. So if you really screen, like the way Iceland screens their people, you will find a small monoclonal protein. But what is the significance? We are not going to treat them. We don't treat MGUS. We don't recommend treatment for smoldering. So we are just going to create a pool of healthy but worried people that, will panic and get tested much more often than they need if we do excessive testing.
If this is done frequently, I think most of the patients will be positive for MJIP.
No, exactly, exactly. I think it's something that, especially in India, I think you all have a very practical way of dealing with patients. You should continue with that. I think it is much more sensible.
True. Well, so there are no questions. So, Dr.
Okay.
Sarkar, a fantastic lecture, and I'm always mesmerized by your way of talking. You are so crystal clear. Every word is very, very clear, and it directly goes into my brain. So, thank
Thank
you.
you. Thanks for the compliments. And please, even after the talk, if people have questions, just email me. I'm happy to help. Take care.
Thank
Bye-bye.
you. Bye.